All right, moving right along. We're now talking about chapter 34, anti-hyperlipidemic drugs. So before we go any further, does everybody know what hyperlipidemia is? Yay or nay? Do we even know what we're treating? Nope. I didn't hear you, Kelsey.
Excessive fat.
Kind of, sort of. It is basically high cholesterol. And cholesterol is like fatty buildup within the vessels. Okay, hyperlipidemia is fatty buildup, fatty deposits within the vessels. And then atherosclerosis is when those fatty deposits harden. So look, I got a good example today. I'm excited about it. My little Scentsy. Look at there. That is a very good example of what it looks like when your vessels are atherosclerotic and you have high cholesterol. What are our patients whose vessels look like this? What are they at risk for? Whoever wants to answer me.
Heart attack.
Heart attack. What else? High blood pressure. What else? One more thing.
Stroke.
Stroke. Yes. Exactly. So y'all know this, right? This does not look normal. We do not want our vessels to look like this. This is legit what your patient's vessels look like when they have high cholesterol and when they have atherosclerosis, okay? So all the drugs, I'm so excited to find this. Like, that's when you know that you're lame and you're a teacher, you get excited about a halfway dried up Scentsy. But it gives you a good idea what it looks like, huh? So,
how did that happen?
because my kitchen was stinky. And I was fixing to put a little wax warmer in it. And I guess it's been in there for a while, like it didn't have a smell anymore. So I guess it just kind of hardened and it didn't. So I just dumped the other wax out.
I have Scentsy. I love Scentsy, and that's never happened to me.
Yeah, this has probably been in there for a minute. That's how. But it worked out for my lesson today. So, all right. So that's what we're talking about. So when we're talking about, if you look at on page 383, cholesterol levels, we have good cholesterol. I hate to say good cholesterol, bad cholesterol. You know, we have to have some, you know, our blood there's a very homeostasis is important. So we have to have a certain amount of deposits of fat in our blood, but we don't want to have that overabundance. So we have good cholesterol, and then we have, you could say, bad cholesterol, and then we have triglycerides, and all of those together make up your total cholesterol. So if you look on page 383, total cholesterol is we want it to be less than 200. And we consider our patients to have high cholesterol if it's greater than 240. And then the HDL, if we get to pick between the two, we want our HDL to be higher and our LDL to be lower when we make up that number. And actually, triglycerides are separate. I told a story. Okay. All right. So low density lipoproteins are LDLs. And when they're elevated, they contribute to atherosclerotic plaque formation, like what I just showed you guys. And that increases our risk for heart disease. But before we even got into this lecture, y'all kind of used your reasoning skills to know that. HDLs take cholesterol from the peripheral cells and they transport it to the liver. So our body needs cholesterol and it needs lipoproteins, but it doesn't need an overabundance. You ever heard too much of anything is not a, I can't, when I go to think of these things that are in my head and then I can't get them out for y'all. You can't have just too much of it. It doesn't make it better if you have a whole lot of it. It means that our that our equilibrium is off and something, it's got to go somewhere, and usually it's attaching to those vessel walls. So LDL plus HDL is going to equal our total protein. So the HDL protects against heart disease at good levels. You know, that's our good cholesterol. The higher the LDL level, the greater risk for heart disease. So if you want to think of that as kind of our bad cholesterol. But all of the drugs that we're talking about, our anti-hyperlipidemics, are going to be used to treat high cholesterol. So that's our big umbrella would be anti-hyperlipidemic drugs. And then our branches from that would be bile acid resins, HMG-CoA reductase inhibitors. Those are our statin drugs. Fibric acid derivatives, and niacin. So just like, I'm gonna keep going back to the lecture on our high blood pressure drugs, we have to somehow figure out a way to interfere with those natural body processes so that our drugs can target what they need to target and that we can get the action that we desire. So we're gonna kind of be talking about the same thing with our cholesterol drugs, okay? So HMG-CoA reductase inhibitors, so not the inhibitors, just the HMG-CoA reductase, is an enzyme that is a catalyst during the manufacture of cholesterol. So in a normal body process, that HMG-CoA reductase, it helps to make that cholesterol. And we said we want cholesterol, right? We can't live with zero cholesterol. But so what it does is it helps manufacture, and it manufactures, and the body does what it needs to with that cholesterol. But if there's too much, we need something to interfere with that process, yes? Okay, so statin drugs inhibit that manufacture of cholesterol, or they promote the breakdown of cholesterol. So they're coming in and they're blocking it and they're stopping that process. So these medications, in turn, lower the blood levels of cholesterol and serum triglycerides. And they increase the good cholesterol, the HDLs. Okay. So if you can remember, this is the good news for HMG-CoA reductase inhibitors. They all end, look in your book on page 391. What do they all end in?
Statin.
Statin. These are our statins. They all end in statin, and they're the mainstay of treatment for cholesterol. Atorvastatin, lovastatin. I don't know if y'all have heard of those drugs or not, but those are your most common drugs to treat high cholesterol. All right. They are used as adjunct to diet and treatment of hyperlipidemia. They are used for primary prevention of coronary events and for secondary prevention of cardiovascular events. So coronary events would be strokes and cardiovascular events would be heart attacks. So those are our two biggest risks with high cholesterol. And these medications are used for prevention of those things. Makes sense, right? All right, so the adverse reactions of these drugs, headache, dizziness, insomnia, memory and cognitive impairment, abdominal issues, flatulence, cramping, constipation, and elevated CPK levels. And rhabdomyolysis is it's very uncommon, but it's something that could take place with these medications. They could be, they could cause some problems. We don't give them to patients with a hypersensitivity of the drugs, and we don't give them to patients with liver disorders. So they're you know, the liver is sensitive to these drugs. So we're not going to give them to patients with a significant history of alcoholism, non-alcohol related liver disease. We really want to pay attention to our patient's liver with these medications.
I have a question.
Yes, ma'am.
So in this book, I've been noticing in the contraindications and precautions for like pregnancy and everything, it'll say in parentheses like pregnancy category X is the example of this. What does that mean?
So there's an appendix in the back of your book. They've changed those categories. It used to be A, B, C, D, E. Let me look up to tell you. But it is remember when we talked about the scheduling of drugs? That's a great question. And I don't want to tell you wrong, so I'm going to look it up. But remember we talked about when we talked about controlled substances, and, you know, Schedule 1 had a higher instance for abuse and Schedule 5 had a lower likelihood of abuse. It's the same with the risk for the fetus, with those lettering systems for pregnancy. But I will look them up for you and tell you real quick what they are, because they have changed in recent years. So it's just the FDA pregnancy categories is what it is. Let's see.
Yeah, I know in like for the LASIK it was saying like category A, B, and C.
So it's probably contraindicated in pregnancy altogether if it's X, but I want to tell you correctly. So hang tight. All right. All right, so category A is adequate and well-controlled studies have failed to demonstrate a risk to the fetus, so they're pretty safe. And then category B, animal reproduction studies have failed to demonstrate a risk to the fetus, but there's no well-controlled studies in pregnant women. So it's still kind of unknown kind of thing. So category X, I'm not going to read them all, but I will post this for y'all. Or I'll just tell you, if you just Google FDA pregnancy category, it's on there and it's accurate. And then so pregnancy category X, studies in animals or humans have demonstrated fetal abnormalities and/or there is positive evidence of fetal risk. So we know that they're dangerous in some sort of way to the fetus. Very good question. Y'all have any other questions? All right. So this is something important, and you should remember it forever, ever, ever, because I feel like I have a really bad memory, but I know that I had some kind of question on the NCLEX about grapefruit juice. Like I don't remember what it was, but I just remember there being a question about grapefruit juice on my NCLEX. Patients on lovastatin and simvastatin should not drink grapefruit juice due to specific enzyme reactions. So HMG-CoA reductase inhibitors, that HMG-CoA reductase, that is an enzyme. It ends in ASE. Grapefruit juice interacts, and it, you know, we talked about our drug-drug interactions, and it causes the medication to not be effective. All right, so the next category, so the first one was statins. HMG, CoA, reductase inhibitors, statins, mainstay of treatment for hyperlipidemia. Okay, moving on. Bile acid resins is the next subcategory. So somebody told me earlier that bile was manufactured and secreted in the liver. That was correct. So bile is manufactured and secreted by the liver, and it's stored in the gallbladder, and it emulsifies fat. It kind of melts it in a way as they pass through the small intestine. Okay? So bile acid resins bind to the bile acids to form an insoluble substance that can't be absorbed by the intestine. So instead of the body reabsorbing that fat, the patients poop it out. Does that make sense? So same at the end of the day, our what we want, you know, our expected outcome for these medications is a lowering of those cholesterol levels. But instead of interfering with that enzyme, we're having, it's making that, those bile acids, you know, not be, they're making them be expelled from the body. So they're used to treat hyperlipidemia. They're also used to treat pruritus associated with biliary obstruction. Pruritus is itching, right? And they are used to dissolve gallstones. So they have a couple more uses than do the statin drugs. If you look at these medications, examples are, I always struggle saying this word, I'm sorry, cholestyramine, cholestyramine, and cholecyvalum. If you think that COL, the primary action is taking place. They're affecting your poop. They're affecting the makeup of your poop, and you're getting rid of some of those insoluble substances, those lipids, rather than them absorbing in your bloodstream. If you want to try to remember them that way, colon, COL, CHOL, you may be able to kind of try to remember them that way. These medications, because they have a lot to do with absorption, they're given either alone or they're given 4 hours after the administration of other drugs. Okay, because we're interfering directly with absorption there, and we don't want to interfere with absorption of other medications. So the good news about this, remember we told you that a lot of times you could rationalize your adverse reactions, your side effects of these medications. They can cause constipation. They could cause aggravation of hemorrhoids, because basically we're bulking up that poo a little bit, you know, with those fatty deposits. Abdominal cramps, flatulence, nausea, and increased bleeding tendencies. They're contraindicated in patients with hypersensitivity to the drugs, and they're contraindicated in patients with biliary obstruction, that bile duct going to the gallbladder. We're going to use them cautiously in patients with diabetes, liver and kidney disease, that's starting to look common, right? And peptic ulcer disease. So I had a question yesterday. It's so hard to tell. Everybody's like, what do I need to know? You're starting to see that patients with liver disease and kidney disease, we're always going to use drugs cautiously in those patients. You know, there's a difference between using cautiously and contraindicated. When it says contraindicated means no. That's kind of like your stop sign. We're not using it in these patients. As always, benefit risk, you know, is going to be evaluated by the physician. And sometimes they will still be used, but more often than not, it's not a good choice to use it. When it says contraindicated, we're not giving it to those patients. All right. Drug-drug interactions. All right, when we talked about bile acid resins, we know that our colon, our large intestine, is the site. Do y'all remember that that's our site where we reabsorb a lot of our essential vitamins? So patients on these bile acid resins are at reduced, they have a risk for reduced absorption of vitamins when they take these drugs. So they may be on supplementation. My plan with the drug-drug interactions, my hope, I'm not saying that you'll never see them on a test, but it's kind of hard to associate them together before you learn about the other drug classes. You know, like when we say that, if I say it interferes with anticoagulants, but you haven't really learned about anticoagulants yet, my hope there is to kind of bring all of that together at the end, and give you a bigger picture of what interferes with what. Does that kind of make sense to you guys? So I'm not saying it's off the hook forever. Like whenever I just said you don't take statins with grapefruit juice, that's something you need to remember forever. But all of these specific, you know, every single one, I'm not going to pull those out to the end, okay? All right, so next category, fibric acid derivatives are fibrates. Good news is, if you want to look on page the bottom of page 391, they kind of have some similarities if you look at them. Fenofibrate, FIB, gemfibrozil, FIB. That ezetimibe, Zetia is a very common one. It doesn't end in that. It's a miscellaneous one, though. It's not a fibrate. So it's really just those two at the bottom. The goal of this drug is to reduce very low density lipoproteins and to stimulate catabolism of triglyceride-rich lipoproteins, ultimately resulting in a decrease in plasma triglycerides and cholesterol. So it's just interfering in a different way. And, you know, everything is a catalyst. I'm going to say that so many times. In the body, it really is so intricately, you know, there's this causes this, causes this. Something is a catalyst for something else. Something is a trigger for something else. So almost all of our medications are going to interfere with that trigger. So that's exactly what fibric acid derivatives do. They stimulate the catabolism of triglyceride-rich lipoproteins, and they decrease those triglyceride levels. Okay. Gemfibrozil, similarly to the bile acid resins, increases the excretion of cholesterol in the feces. It reduces the production of triglycerides by the liver, and it lowers those lipid levels. It is used primarily for high triglycerides. And then the fenofibrate is used as adjunct treatment for reducing LDLs. Very, very similar side effects to the bile acid resins: nausea, vomiting, GI upset, diarrhea, and gallstones. And we're going to be super careful with our patients with hepatic and renal dysfunction. And we're going to use it cautiously in patients with peptic ulcer disease, diabetes, and during pregnancy. Okay. Miscellaneous drugs under that umbrella. So when we went through those first three classes, these are just some miscellaneous. They lower lipid levels because that's our ultimate goal. That's what we want at the end of the day. They're used as adjunct treatment to lower very high serum triglyceride levels, especially in patients that are at risk for pancreatitis. They cause GI problems. Niacin causes flushing of the skin, specifically niacin. That's a different thing than what y'all have seen before. And Zetia is a very common, it's one of the most commonly ones that I have seen prescribed. So I would remember both the generic and then and the brand name for that one. All right, we're being super careful. Patients who have a high alcohol consumption, unstable angina, gout, and pregnancy. And we're not giving them to patients who have a lot of bleeding disorders or liver disease. All right. So this is our nursing process. So if y'all were making a little word map like I always talk about, anti-hyperlipidemic drugs and your subclasses underneath them. Try to think about all those subclasses that go underneath them and pick out those important drugs in those classes, like I told you. HMG, CoA reductase inhibitors, what do they end in? Yes. All right, so when we're given these medications, we want to take their dietary history, because what might we need to educate them on if they have high cholesterol? You cut out a little bit. You said their diet, huh? Yeah. So yeah, we're gonna talk about fatty foods. We're gonna talk about all the things that can increase those cholesterol levels. We're gonna record their vital signs. Not always, but very frequently, if a patient has high cholesterol, they may also have high blood pressure. So we want to keep, we want to keep an eye on those things. And not always, they're not the same and they don't go hand in hand. But a lot of time, if there is sclerosis of the veins and there's a lot of fatty buildup, pressure is a little bit on the higher side. Xanthomas. Have y'all ever heard of a xanthoma? Xanthomas are actually cholesterol buildup around the eyes. That's a Google a picture. Now you're gonna be looking at everybody and trying to figure out. They're different from skin tags. They're not the same as skin tags. But patients with very high cholesterol often have buildup around the eyes of fatty deposits, and they're known as xanthomas. So we might want to document if our patients have those. We want to monitor liver function test, because remember we said these medications, so liver is the place that we're processing this bile, and we're giving things that interfere, the bile acid resins, or we're kind of coming in and we're interfering with some of those processes. So we really want to know what their liver functions are. Do y'all know, have y'all learned like normal levels for like a liver panel, or no? Not quite? Okay. I'm not going to focus on that for y'all, but I do need y'all to know that y'all are monitoring liver function studies. We're going to frequently monitor their blood cholesterol and triglyceride levels. We're going to monitor constipation. We're going to increase fluid intake if they're super constipated. All of these are easy nursing interventions that can aid your patient, when they're on these medications. We can tell them to eat foods high in fiber and exercise daily. And some of their diagnosis might be risk for imbalanced nutrition, because we said those bile acid resins may interfere with their ability to absorb some of those essential vitamins. We're going to monitor for vitamin K deficiencies. Rhabdomyolysis or rhabdomyolysis is a condition in which the muscles kind of like start to break down. So if your patient starts saying that they're having muscle pain and weakness and fever and malaise, their muscles are being attacked internally. And that is a side effect that is a severe adverse reaction with these medications. So that's something that you need to be alert for. When we educate our patients, we're going to provide them with the recommended diet. We're going to explain the importance of taking their drugs as prescribed. And we're going to explain the importance of contacting their primary care provider if any symptoms occur. We don't want them to just write it off and write it off and write it off. And it's progressively getting worse every single day. We want to have that open line of communication, just like we always should have with our patients. All right. Atherosclerosis is a disorder in which lipid deposits accumulate in the lining of vessels. Yes, it is. Cholesterol and triglycerides are two lipids in our blood. Elevation of one or both is termed hyperlipidemia. Yes, it is. the following statement true or false? Bile acid resins are frequently called statin drugs, and these lower blood level of cholesterol and density lipoproteins. Do y'all know that one? That is false. HMG CoA reductase inhibitors are called statins. So keep those. Those very important. You're going to see, I would say, almost as many people are on blood pressure medication seem like they're on cholesterol medication. Don't know if that's just the population of patients that I generally take care of, or if that's our, state as a whole. But knowing the difference between all of these medications is incredibly important. Something that I want to tell y'all. A lot of patients with high blood pressure will have high cholesterol, but a patient's blood pressure does not determine if you give their high cholesterol medication. Did everybody hear that? Because it does not have an effect on blood pressure. Lovastatin does not affect their blood pressure. Okay? Niacin, not going to affect their blood pressure. It's not something, diuretics will directly affect their blood pressure. And, all of the other medications under the umbrella of antihypertensives will affect their blood pressure. These primarily affect their cholesterol. And there's no way for you to measure that prior to administration other than lab tests, but those are done over time. It's not something you're going to have on hand every time you administer these drugs. I feel like in practice, a lot of students get that confused. So I don't want y'all to do that. Does that make sense to y'all? A lot of patients with high blood pressure have high cholesterol, but they're two totally different things. Okay? Questions? I'm going to go ahead and end this recording, and then we'll have some questions.